some clinicians have prepared what are called the wound bed preparations for us. This started about 20 years ago, and the way it started was that with the advent of many new dressings that were now available on the market, clinicians were realizing that the results that they were getting on their patients were not the same as the results on the published evidence. So authors like Rob Schneider and Gary Sibbald started preparing these wound bed preparations, and one of the first ones that came out was referred to as DINE, which is the vitalized tissue, infection and inflammation, moisture balance and edge of the wound. However, the wound bed preparation has got 7 steps that we will go through together. The first step we already alluded to in the previous sessions, where we talked about identifying and treating the cause. Understanding the etiology of the wound is really important because the standard of care of wounds is totally different. If we are managing a venous leg ulcer, if we are managing a diabetic foot ulcer, if we are managing a surgical incision, the standard of care is really different. So getting identification of what we have in front of us is really important. And sometimes, as we'll see, for example, when we're talking about leg ulcers, sometimes we might be confused because there are atypical wounds which you don't see every day. So once we look at a wound and we are not entirely sure, make sure that we call on our colleagues to identify that wound correctly. Once you identified the etiology, we go back to the evidence-based practice. What is the evidence telling us for the exact standard of care that would give us the best solutions? And then going back to the previous session where we talked about the holistic assessment and management of the patient and the wound. The second step we already talked about previously as well is patient-centered concerns, patient-centered care. Listening to the patients is sometimes even more important to what we talk to with the patients, understanding their anguish, their anxiety. We alluded to the type of partnership that we have with the patient. Many years ago, we used to talk about compliance, and compliance is basically us telling the patient what to do and the patient has to follow. Nowadays, patients have got a lot of information out there. They just take out their phone and they can Google whatever they want to look at. So the importance is to speak to the patients in order to increase what was alluded to then was compliance, which is basically getting a bit of a partnership between us and the patient and reaching together an agreement for the protocol of care. One of the only good things that came out of COVID times in the past few years was that we actually need to empower the patient, give them as much information as possible so that they can even take care of themselves. So more importantly, when we are talking with our patients, give them the different options, but also listen to them about what is really worrying them and making sure that our treatment of care does target these concerns. The third step, which is also extremely important, is understanding if we can actually heal our wound, because some wounds are unfortunately non-healable wounds. We are talking, for example, here about wounds which have irreversible ischemia. We are talking here about wounds which are a cancer, maybe at a stage 4 cancer. So if we cannot change the factors that are not allowing the wound to heal, then we are talking about these wounds which are non-healable, which are different from hard to heal wounds, because then we can talk about maintenance care, that we take care of whatever problem we have now. For example, we talked about ischemic wounds, where once we have an ischemic wound without circulation, and then we take the patient and revascularize that lower limb, then that changes to a healable wound. So if we have an unhealable wound, do we still follow the same wound bed preparation? And the answer to that simply is no. A very nice publication that came out from Canada by Kevin Wu was that he was talking about a new type of acronym, which is called HOPES. So HOPES basically is how we take care of these palliative wounds. HOPES stand for control of hemorrhage, control of odor, pain, exudate, and superficial infection. So the whole idea behind it is that you make the patient as comfortable as possible and making sure that the wound doesn't deteriorate as much as possible. But let's concentrate on healable wounds, and with healable wounds now we move to the DIME. D can refer to debridement, the vitalized tissue. You might have heard of time as well, which is almost the same thing as dime, with T being tissue. So what is the aim of debridement? The aim of debridement is basically removing all what is in the wounds which shouldn't be there. We are talking about slough, we are talking about eschar, and that is important because once you remove that, you are reducing the burden on the wound, you are allowing the inspection of the wound properly, making sure that we are reducing the risk of infection, and making sure that we are converting that hard to heal or chronic wound into a wound which starts healing again. If we look at definitions of debridement, one of the most extensive definitions we have is the UMA definition, which you will find on your textbooks as well. But UMA basically tells us that it is the art of removing all the material in the wound which will not allow wound healing to occur, and making sure that once we remove this, we are removing the burden on the wound to liberate the wound edges and the tissue to start the healing process again. By removing all of these sources that will decrease the chances of the wound to heal, we are also reducing the malodor, we are also reducing the sources of infection, we are also reducing the sources that will increase the exudate, and therefore, by means of using debridement, we are enhancing the health-related quality of life of our patients. So what are the targets of debridement? The first one, what we talked about, is removing of the non-viable tissue, which will at the end decrease the malodor, will decrease the exudate and the chances of infection. It will stimulate the growth and also improve the quality of life of the patients. So debridement has always been an integral part of wound management since time immemorial, but now we understand why and how debridement will enhance healing. One of the things that we talk about also is there a differentiating factor between debridement and the sloughing? There have been quite a few debates about this, and one of the suggestions is that slough and eschar are different from each other, and the approach towards removing slough and towards removing eschar can be quite differentiated. So newer textbooks nowadays and newer publications are separating the sloughing and debridement, although the achievement would be the same thing, that we will make the wound better by enhancing the healing process. When we look at the methodologies of doing it, there are 5 main types of debridement / the sloughing if you want, which is surgical, enzymatic, autolytic, biosurgical, and mechanical. One of the important things to understand is what type of debridement are we going to use. Depends on the wound, depends on the patient, depends on our licensure sometimes, because not all of us are licensed to do, for example, surgical or sharp debridement. But the most important thing is understanding what your objective is to reach when you are doing debridement. Some methods can actually be done sequentially. For example, we have a wound which is filled up with fibrinous tissue which is stuck to the wound bed. So we use autolytic debridement, you soften that fibrin, and then you can do mechanical or surgical debridement after that. Some methods are easier, some methods will take longer than the other. Some methods might not be available for you. For example, if you don't have biosurgical, that is maggot therapy, available, you cannot use it. Again, look at the evidence. There is a lot of evidence behind the different types of debridement you can use. Nowadays we have a modern type of dressings that can help you with, especially with the dissolving part of the wound bed. So again, look at what the evidence is telling us and make sure that you are applying the best method according to the type of wound that you are looking at. Moving to the next letter, we are talking about I, which is inflammation and infection. The inflammatory process, as we said previously, is part of the normal cycle of wound healing. However, we have types of wounds, for example, chronic wounds, but also wounds which are acute and become stalled, where the wound microenvironment is not as it should be. Nothing is in balance. We have a total imbalance in the wound bed where whatever should be at a low level, for example, matrix metalloproteinases, are at excessive levels. You can have biofilms as well that can create a whole issue inside the wound. So if your wound is not progressing at the rate that it should at, and it is stuck in the inflammatory phase, make sure that you are removing that biofilm, make sure that you are keeping the levels of MMPs in a good level by means of using dressings that will reduce the levels of these MMPs. I, as we said, is also infection. So infection, again, in a very simplistic method of examples, is the multiplication of microorganisms that will overwhelm the body's defenses. So when we're talking about the body's defenses here, we are talking about the PNMs, the neutrophils, the white blood cells, the enzymes, the proteases, etc., which in the normal process of healing will take care of the microorganisms. However, there are chances where these microorganisms will overwhelm the body defenses. So if we look at a very important document by the IWII, the Wound Infection Continuum, they tell us about the different stages that we can look at in the wound. So first of all wounds are contaminated. There are no wounds which are sterile. However, the microorganisms, the free-floating planktonic microorganisms, can be easily taken care by the body and the host defenses. They can start proliferating. However, at this stage, which is colonization, the proliferation is not enough to trigger off a reaction. Once these microorganisms are getting more in numbers and in virulence, then the wound can become locally infected. And when we look at local infection, you can have the overt or classical signs and symptoms of infection, but also the covert, the subtle signs and symptoms. And you have a whole list of these signs and symptoms in your textbook as well. The important thing is the management of this local infection. So if you have a wound which is contaminated or colonized, the IWII suggests that we don't need to do anything, we just be vigilant. However, if we have local infection, then we can treat the local infection by means of a local antimicrobial. One tool that can help you understand better the signs and symptoms of local infection is the therapeutic index, or the TILI score, where it gives you a set of marks and signs and symptoms that will identify local infection. And again, this is referred to in your textbook. Now, if we have the microorganisms, apart from just being in the wound, start spreading into tissue around the wound where we have spreading infection. Usually one of the first signs and symptoms is that we have extended erythema of about 2 centimeters, but we can have induration, we can have crepitations as well there. That means that now the microorganisms are moving into the tissues surrounding the wound bed. So when that happens, apart from the local antimicrobial, we need the systematic antibiotics as well. A systematic infection occurs when the microorganisms start invading the whole body. They start affecting other organs. Your patients will become more sick, and this is a very difficult situation that can also lead to patient mortality. Another thing that we have been talking quite a bit about in the past few years is biofilm. So biofilm is predominantly in chronic wounds, but latest evidence has showed us that even sometimes in stalled acute wounds, biofilm can be present as well. So what is this biofilm? If you need to understand biofilm quite easily, the first people in medical health that started talking about biofilm was our colleagues, the dentists. When you wake up in the morning, you feel like a slime on your teeth. That is actually a biofilm. And although you brushed your teeth in the evening, by the morning, a few hours later, that biofilm will have reformed again and will start us thinking about how we can manage. So what is a biofilm? A biofilm starts off with these free-floating planktonic microorganisms that start attaching themselves to the wound bed, getting stronger attachment, getting more microorganisms into a colony, and they start secreting over them a kind of a gel which is called the extracellular polymeric membrane, which protects them against any outer effect. So this gel makes them impermeable, and the body's defenses, as well as your antimicrobials and antibiotics, won't be able to infiltrate. They continue to grow and mature, and once that happens, then they start spreading all over the wound. And the big problem with biofilm is that even if we remove it mechanically, like we did with our toothbrush, the EPS will start forming even within 6 to 12 hours. So the challenge here is, how are we going to avoid that once we remove the biofilm, it doesn't come back again? Should we change the dressing twice a day? Definitely does not make sense. So what do we need to do? So in order to manage a biofilm, the first thing that we need to do is to remove it mechanically. After that, we kill the microorganisms by means of specialized cleansers, but even antimicrobials, for example, silver. And then we have to use a dressing that will not allow the biofilm to form again, because it continuously cleans. One example of these type of dressings are polyacrylate fibers that will not allow it to happen. Again, evidence-based practice. Make sure that whoever is telling you that their dressing is anti-biofilm, look at what the evidence tells you, because there aren't a lot of dressings that are really anti-biofilm dressings. The next step is moisture balance. We've talked about our dear friend Dr. George De Winter from the UK, who did that study on these animals, where they showed that faster healing occurs and better healing occurs once you get moisture. What we understand nowadays is that moist wound healing environment will allow the cells to function properly. For example, one of the most important cells in the proliferative phase are the fibroblasts, and we definitely know that fibroblast needs a moisture balance in order to heal the wound. One very important study that followed this study by George Winter was a study by Hinman and Maybach 1 year later, where they followed the study now on humans. Why was that study very important? Was because now we know that it's not just on animals but also on humans that a moist wound healing environment works. But one thing that they proved very well in that study was removing an old wives' tale, what they used to think that moisture will help microorganisms to proliferate, the exact opposite is true. The exact opposite is that that moist wound healing environment will allow the natural host defenses to function better, and therefore the moist environment actually reduces the chance of wound infection, enhances the health-related quality of life of your patients because the wound healing is better and the wound heals faster as well. So the last step, the seventh step, is the E, epithelialization. What is true for things which are not wound care might not be true for wound care. What are we saying here? That many times we say that thinking out of the box is very good. With wound care, please first think in the box. What do I mean here? What I mean is that first look at if you've done the DIM properly. Have we treated the etiology? Have we done a proper debridement and desloughing? Do we have a good control over the infection and inflammation? Do we have a balanced moist wound healing environment? If we are doing that in a correct way, but the wound is still not healing, then we can think of adjunct therapies to allow that epithelialization to occur. So when we're looking at the wound bed preparation, it is a template for us to do it in a systematic way. Start off with what we discussed in the previous session, do a proper holistic assessment, look at the patient-centered concerns, what is causing the wound, treat the etiology of the wound, then look at debridement of the devitalized tissue. Also remember that looking at eschar, should we debride or should we not debride, is not an easy decision to take. We need to look at the circulation as well, and also then going on to the management of infection or the prevention of infection, looking if our patient's wound is stalled in the inflammatory process. We have to remove the MMPs, moisture balance, and adjunct therapies. So how can we do that in relation to what dressings we are using? For example, if we're talking about debridement, there are a lot of dressings, as we said previously, that can help you with debridement. For example, autolytic debridement, we've been using hydrogels and hydrocolloids for a long time, but also looking at newer dressings like the polyacrylate fibers that we mentioned, that will help you remove the slough very easily because the slough attaches to the fibers. When you remove the dressing, you are removing the dressing atraumatically. If we are talking about inflammation, there are dressings that help you with the inflammation, for example, sucrose octosulfate dressings, which will help reduce the inflammatory process. But also, I allude to infection, as we said, there's a huge amount of antimicrobials that we can use. Make sure that the antimicrobials that you are using are tough on the microorganisms, but gentle on the wound. There are antimicrobials because of the high level of antimicrobials inside the dressing that can become cytotoxic. So make sure that when you are looking at these dressings, look at the evidence if they remove the infection, but also trigger the wound healing process. When we are talking about moisture balance, is the wound dry or is the wound wet? So if you want to increase the moisture inside the wound, for example, you can use things like the hydrogels, which are quite simple to use. Remember, when you are using these type of gels, that you protect the peri-wound skin to avoid maceration. If we have excessive exudate, what is causing the exudate? It's usually the slough and infection. Remove the slough and infection, your exudate will start going down, but you can have things like the foam dressings that can help you pick up that exudate as well. When it comes to epithelialization, again, remember that we need to continue with a moisture balance. We need to protect the dressing. Make sure that you are using atraumatic dressings, that when you remove, even in the proliferative stage, that when you remove the dressing, it is not causing trauma to the wound bed, and adjunct therapies. There's a lot of these adjunct therapies out there nowadays. Remember that also, however, to look at the cost-benefit analysis of these type of modalities, because there are type of dressings that are really expensive that are probably not that cost effective, but there are dressings like, for example, we mentioned the sucrose octasulfate dressing that can help us to reduce the inflammation, that can help us propel the wound back to the healing stages.